স্যার আমরা লাইভে আছি, শুরু করতে পারি।
Good evening. Welcome to today's webinar. Today our topic is on myocarditis, which will be delivered by Dr. Abida. And next topic will be COVID-19 and cardiovascular disease. It will be presented by Dr. Ishaquzzaman. And next, our topic is cardiac tumors, which will be presented by Dr. Mohammad Shamim Chaudhary. Teachers, friends, and colleagues, today we have two renowned cardiologists of this country as panelists. They are Professor Amal Chaudhary, who is the professor of cardiology, NICVD, and another is Dr. Mahmudullah Firoz, who is the assistant professor of cardiology, Sir Salimullah Medical College and Hospital. Now, at the beginning of the webinar, I'll request Professor Fazila Malik Madam to say something on this occasion and start the session. Madam, please.
Thank you, Dhiman. So indeed, it's really a great honor for us that today we have with us as panel of experts who will be sharing their perspectives as an examiner of what questions might be asked from this subject, Dr. Firoz and Professor Amol. We both know that these two persons are great academicians. They're really interested in sharing their knowledge with their students. So I'm sure that our students will be really greatly benefited from their knowledge and from their wisdom. And today we have three great speakers. I mean, these three, they really give great presentations. So I'm really looking forward to learning from them. And without further ado, I would request our moderator, who's also very experienced, Dr. Dhiman Boni, to conduct the session. Thank you.
Thank you, madam, for the welcome speech. Now, our first speaker is Dr. Abida, who is the registrar of National Heart Foundation and Hospital. He speaks very well, and he will speak on myocarditis. Dr. Abida, please share your screen.
Thank you, sir. Honorable panelist, respected moderator, my respected teachers, students, and dear learned audience, Assalamu alaikum. I'm Dr. Abida Tasnim Reza, Registrar, National Heart Foundation Hospital and Research Institute. I'll be talking on the topic myocarditis. Let me first start with a case scenario. A 22-year-old student presented with fatigue, shortness of breath, and palpitation for 2 days with prior history of flu-like illness. On examination, she has tachycardia with hypertension and bilateral basal crepitation of lungs, no prior history of any coronary artery disease or any cardiac risk factors. Her C-reactive protein was elevated and the biomarkers were also elevated. Her ECG showed sinus tachycardia with non-specific STT changes. And chest X-ray posterior anterior view shows bilateral pulmonary edema. Echocardiography was done showing regional wall motion abnormality with systolic dysfunction. So the question is, what is the most likely diagnosis in this patient? A, pericarditis, B, myocarditis, C, myopericarditis, D, acute coronary syndrome. And what is the next step for investigation in this patient? A, is it coronary angiogram, CT angiogram, cardiac MRI, or endomyocardial biopsy? Hopefully, at the end of this presentation, we'll be able to answer all these questions. So the topics that I am going to talk on myocarditis are these. And the definition, as the name implies, it is defined as inflammatory disease of the myocardium diagnosed by established histological, immunological, and immunohistochemical criteria. When myocarditis is associated with cardiac dysfunction, it is known as inflammatory cardiomyopathy. Now, what do you mean by established histological criteria? It is also known as Dallas criteria. That is when there is inflammatory infiltrate in the myocardium with myocyte degeneration and necrosis, and of course non-ischemic origin. Abnormal inflammatory infiltrate are, that is, if the WBC count is more than or equal to 14, monocyte 4, and CD3 positive T lymphocytes more than or equal to 7 in millimeter square. Now, the epidemiology is actually unknown because it is overly underdiagnosed, but it has been known to be the cause of sudden death in approximately 10% of adults. Now, we classify myocarditis based on different parameters. One is clinicopathologic, one is histologic, and another one is clinical. Now, clinicopathological criteria of myocarditis is the classification are acute myocarditis, which is the most common, about 65%, chronic active and chronic persistent myocarditis, and rest is fulminant myocarditis. Acute myocarditis has an indistinct onset, but it causes moderate cardiovascular compromise and often results in cardiac dysfunction or subsequent death. Whereas the chronic active and chronic persistent are mild to moderate in nature. But what about the fulminant myocarditis? It has a distinct onset, but it either may cause rapid complete resolution or rapid deterioration and death. Now, the histopathological classification depends on biopsy. It is also known as the Dallas classification, depending on presence of myocarditis with or without fibrosis. Another clinical classification depending on the diagnostic certainty include possible subclinical, probable acute, and definite acute myocarditis. I'll explain it at the end of my presentation. Now comes the etiology. It may be due to infectious or non-infectious cause. The non-infectious cause again include the toxic causes such as drugs, heavy metals, physical agents, and immune-mediated cause. These are the common causes that are responsible for myocarditis. Most common are adenovirus, cytomegalovirus, Coxsackie-B virus, HIV, and very recently the SARS-CoV-2 virus. Others include salmonella, leishmania, ethanol, and different types of autoimmune conditions, as well as hypereosinophilia syndrome. Now comes to the pathogenesis. In phase 1 of disease, that is in week 1, what happens is, in case of viral myocarditis, viral enters into the myocardium, resulting in direct myocardial injury. And in stage 2, what happens is the viral clearance starts, but the cell-mediated immunity and humoral immunity takes part. As a result, either the patient improves, resulting in phase 3, that is disease resolution after 4 weeks, or it may turn into chronic myocarditis, and in some cases, it may turn into a dilated cardiomyopathy cases. Both genetic background as well as the infectious and non-infectious agents can take place in causing the pathogenesis of myocarditis, and the end spectrum is dilated cardiomyopathy. Now, clinical features of myocarditis. It has to be remembered that most commonly, most of the patients are asymptomatic. If the patients are symptomatic, the complaints are as all other cardiovascular disease complaints, such as shortness of breath, chest pain, palpitations, dizziness or syncope, and sudden cardiac death. In 60% of cases, there are constitutional symptoms 1 to 2 weeks before the onset of actual disease, such as fever, malaise, fatigue, arthralgias, etc. Also, history of pharyngitis, tonsillitis, GI tract infection. It is very important to take history of drugs, exposure to any toxin, and any history of allergy during history. Now, I'd like to explain some of the points of the clinical features. That is, chest pain is absent in most cases of acute myocarditis. If it is associated with mild persistent chest pain, then it is actually acute myopericarditis. It is usually dull or atypical in variety. The symptoms of heart failure include dyspnea, fatigue, and edema, and it is the hallmark of features. If any patient presents with new congestive heart failure symptom in a young patient, or if the patient has no known coronary artery disease with a history of an antecedent viral syndrome, then we have to consider myocarditis as the diagnosis. Palpitations and dizziness, sudden cardiac death may result from ventricular arrhythmias or conduction abnormalities. There has been also noted systemic and pulmonary thromboembolism. Now, the physical examination. On observation of the patient, we might see the patients as ill-looking if the patient has features of congestive heart failure, the decubitus may be propped up. If the patient is in shock, patient's urine output may be reduced. Now, what about the general examinations? There may be fever, tachycardia, or bradycardia if any conduction disorders. Hypotension may be present often, patient may often present with cardiogenic shock, raised jugular venous pressure, and peripheral edema. Now, the cardiovascular system and respiratory examination. The first heart sound may be muffled if associated with pericarditis and pericardial effusion. In acute decompensated heart failure, there may be third and fourth heart sound with gallop, and as well as there may be murmur of mitral regurgitation. Pericardial rub may be present if associated with pericarditis. There may be bilateral crepitations as well on auscultation of lungs. Some specific findings may be present depending on some specific disease, such as enlarged lymph node in sarcoidosis, erythema marginatum, subcutaneous nodules, joint inflammation in acute rheumatic fever, or pruritic maculopapular rash in hypersensitive or eosinophilic myocarditis. Now, what are the investigations that we need to do in these patients? First of all, the blood investigations. Complete blood count will show often increased WBC count, lymphocytosis, as well as eosinophilia in eosinophilic myocarditis. Acute phase reactants such as erythrocyte sedimentation rate, the C-reactive protein may be elevated. Serum viral antibody titers may be increased as well as serum cardiac enzymes. It has been noted that at least 50% of the patient has raised cardiac troponin I or T, and CKMB is elevated in only 7.5% patient. Other routine baseline investigations should be done, as well as some disease-specific tests such as anti-dsDNA, anti-O antibody, ANCA, etc. Now, the definitive investigations are the ECG, chest X-ray, echocardiography, cardiac MRI, endomyocardial biopsy, and in some cases, cardiac catheterization if there is any confusion regarding acute coronary syndrome. Now, what are the common ECG findings? Most of the cases, there may be sinus tachycardia, non-specific STT changes, features of acute pericarditis with diffuse concave ST elevation with peer depression. There may be conduction disorders and tachyarrhythmias. ECG may also be normal. Chest X-ray, in many cases, it may be normal, but sometimes there may be cardiomegaly. If there is any associated pericardial effusion, it may be globular, along with congestion and pulmonary edema in some patients. Now, in echocardiography, what are the common findings? There may be regional or global abnormality, as well as in chronic cases, there may be ventricular dilatation. In early phase, there may be increased ventricular wall thickness due to edema of the myocardium. Pericardial effusion may be present along with thrombi, and also mitral and tricuspid regurgitation. Now, if we try to differentiate between acute myocarditis versus dilated cardiomyopathy on echocardiography, definitely history is very important, but there are some points that may differentiate from acute and dilated cardiomyopathy. Generally, the left ventricle cavity is normal in acute myocarditis, whereas the dilated cardiomyopathy, especially in as it is a long-term case, the left ventricular cavity is always dilated. And there may be increased LV wall thickness in acute myocarditis, as these are already also commonly associated with pericarditis. Pericardial effusion is also common in acute myocarditis. The next investigation is cardiac MRI. It is a very important test for diagnosis of myocarditis because it can give an important clue. It may show the T2 weighted images, regional or global myocardial signal intensity, as well as there may be features of late gadolinium enhancement in T1 weighted images. These are very much diagnostic of myocarditis. Now, the endomyocardial biopsy is the gold standard for diagnosis of myocarditis. And for this, I'd like to share just a slide how this endomyocardial biopsy is done. It is a relatively safe procedure with mortality only less than 0.4%. So endomyocardial biopsy is done by biopsy, and it may be we can take right heart biopsy or left heart biopsy. In left heart biopsy, the femoral radial artery approach is taken. In right heart biopsy, most commonly internal jugular approach is taken. So the biopsy is inserted through the vascular access sheath, and after introduction in the heart, we confirm the position of the biopsy through either fluoroscopy or echocardiography. And at least four samples should be taken from the right heart, from the interventricular surface, and the size of the biopsy tissue should be 1 to 2 millimeter. And then we need to take the biopsy material in formalin, and we may see it under light microscopy, and some of it should be frozen by nitric oxide, and then it should be sent for viral PCR as well as the immunohistochemistry markers. So this shows the histological features. So endomyocardial biopsy, other than myocarditis, it can be used for diagnosis of heart failure of unknown origin, such as cardiac sarcoidosis, storage diseases such as hemochromatosis, ARVC, restrictive cardiomyopathy, in diagnosis of cardiac masses, also surveillance of heart transplant patients. Now, the three-tiered clinical classification, as I have mentioned, the CI signs, symptoms, and the investigations. If there is patient has no sign symptoms, but if any of these, like if the biomarker or is raised, or their ECG is abnormal, or echo or cardiac MRI is abnormal, any one abnormality if present, then it is possible. If the sign symptom as well as any one of these investigation is present, then it is probable. And for definite myocarditis, we need histologic or immunohistologic evidence. So treatment modalities is most often self-limited without any sequelae. General measures include bed rest, avoidance of strenuous activity, and salt and fluid restriction in heart failure patients. Drug therapy is mainly symptomatic with analgesics, anti-inflammatory drugs, heart failure management, anticoagulant therapy, as well as immunosuppression with prednisone and azathioprine in some cases, and IVIG has been implemented. The specific, depending on the different causative agents we might adopt, include the IVIG and corticosteroids and NSAIDs and some monoclonal antibodies. The last step, interventional surgery, that is cardiac transplantation, is indicated only when there is severe acute myocarditis and patient is not surviving. So essential of diagnosis of myocarditis is we need a very good history. Next, we have to do some biomarkers. Then we need to do some imaging like echocardiography and cardiac MRI. And ultimately, endomyocardial biopsy will give us the definite diagnosis. So let's go back to the case scenario and the questions that I've asked. So what is the most likely diagnosis in the 22-year-old student who had features of heart failure as well as the history of viral illness 7 days back? So it is most probably that it is myocarditis. And next step for investigation, if you want to go for the confirmatory diagnosis, it would be endomyocardial biopsy. So that's it. Thank you. Thank you for your patient hearing.
Thank you, Dr. Abida, for your brilliant lecture on myocarditis, touching every point. Now, Madam Isha give the lecture on COVID. Then we'll have the discussion on myocarditis and COVID myocarditis. Okay, Madam?
Yes, of course.
Yeah. Our next presenter is Dr. Ishraq Zaman. He is the consultant of cardiology and deputy director of clinical National Heart Foundation Hospital and Research Institute. He will be presenting on COVID-19 and cardiovascular disease. Dr. Ishraq Zaman, please.
Thank you, sir. Respected moderator, honorable expert panelist, teachers, learned audience, assalamu alaikum. So I'm Dr. Ishraq Zaman, consultant cardiologist, going to talk about the COVID-19 and cardiovascular diseases. We are definitely going through a difficult period. though for the last few months, the cases are declining, but still it's very early to get relaxed. So let's go through cases. 8 years old normotensive non-diabetic patients attended emergency with complaints of cough and dyspnea for 10 days. He was hemodynamically stable but required oxygen to keep saturation more than 95%. Heart sounds were normal, bilateral basal crackles were audible. And this was his ECG showing the anterior MI, and this is his X-ray showing the few opposites in the lower zones. And these are his lab results showing all the inflammatory markers are elevated, with also D-dimer is elevated, indicating the prothrombotic state, and his RT-PCR is positive. And another patient, a post-CABG patient, developed shortness of breath. He could not maintain saturation without oxygen, and he was hemodynamically stable. And these are his lab investigations. Again, all the inflammatory markers are elevated, but the RT-PCR is negative. So then what to do? And so we do, and the X-ray definitely showing the bilateral patchy opposites, and the HRCT when it was done, it shows the ground glass appearance and the opposites in the posterior zone. Basically, actually, it involved more than 75% of the lungs. So though the hallmark of COVID-19 is respiratory involvement, ranging from mild upper respiratory symptoms to acute respiratory distress syndrome, severe COVID-19 imparts multi-organ involvement. In ICU patients, 20% of patients develop cardiovascular complications. And if the cardiovascular involvement is there, then it portends significantly elevated risk of in-hospital mortality, about 50 to 51%. So who are the vulnerable patients? So patients with cardiovascular risk factors, advanced age, obesity, hypertension, and diabetes, pre-existing cardiovascular disease and pulmonary disease. As we know that these patients might have overexpressed angiotensin-converting enzyme, which helps to bind coronavirus. And also they have attenuated immunity, and their lungs and as well as cardiac functions are impaired. So if we look at the structures of the SARS coronavirus, this is a crown-like structure with 4 proteins. S or spike proteins actually helps to bind to the angiotensin converting enzyme 2 receptor, but by the help of priming by transmembrane protein, then it fused with the membrane and it enters to the host cell. We know that angiotensin converting enzyme 2 actually are in abundance in nasal, oral mucosa, nasopharynx, in the lungs, especially in the pneumocytes type 2, cardiomyocytes, endothelial cells, pericytes, renal cells, as well as gastrointestinal tract. This has a very much protective mechanism for the host cells, as it catalyzes angiotensin 2 to angiotensin 1 to 7. So when the virus enters to the cell, the downregulation of this angiotensin converting enzyme 2 protein actually exposes the host cells to the harmful effect of the angiotensin 2. After virus enters to the cell, it ignites the inflammatory cascades. Often we know this is called cytokine storm, where the many cytokines and chemokines are released, and it causing the destructions and dysfunctions of the many organs and cells. So elevations in inflammatory markers actually give us the clue of a cytokine storm, like ferritin, interleukin 6, lactate dehydrogenase, C-reactive protein, procalcitonin, D-dimer, and leukocyte count. So overall, besides the cytokine-mediated injury, the myocarditis is one of the manifestations of COVID-19, as Dr. Abida already told about the myocarditis. COVID-19 myocarditis is actually in the basic of pathophysiology. It doesn't differ from the other viral myocarditis. So direct viral injury or immune-mediated injury is the underlying mechanism of myocarditis. As the lungs is involved, so hypoxia and respiratory failure also induce the cardiac decompensations, as well as microvascular thrombosis. Arrhythmia also causes the myocardial injury. And it should be mentioned that stress cardiomyopathy is another manifestations of COVID-19. So the cytokine storm and the direct endothelial injury causes often plaque ruptures, coronary spasm, and the presence of hypercoagulable states causes the acute coronary syndrome, ST elevation MI or non-ST elevation MI, as I have told about the case in this hospital. And arrhythmia is another bad prognostic factor in COVID-19 cardiovascular disease. The downregulation of downregulation of angiotensin converting enzyme 2 actually activates the AT1R pathway activation, and so inflammatory cytokines increases the oxidation of CMK2 protein kinase, and it results in overly synthesized cardiomyocytes, and the arrhythmia can start anytime, and it can be manifested as atrial fibrillation, ventricular tachycardia, ventricular fibrillation. So these are the spectrum of cardiovascular complications in COVID-19, from acute coronary syndrome, myocarditis, stress cardiomyopathy, arrhythmia, acute heart failure, pericardial effusion, shock, cardiac arrest, and Kawasaki disease in children. So a patient with acute coronary syndrome and COVID-19 may present with chest pain, elevated troponin, valve motion abnormality, and ECG findings of ST segment depression or elevation. And if it is without obstructive coronary artery disease, the patient may have other cardiac symptoms with elevated troponin. Arrhythmias may manifest it as atrial arrhythmias, ventricular tachycardia, fibrillation, or complete heart block. Heart failure may occur with acute de novo systolic dysfunctions in case of myocarditis or myopericarditis, or cytokine-mediated cardiomyopathy, or even stress-induced cardiomyopathy, and also acute on chronic decompensated systolic dysfunction may occur. Pericardial effusion sometimes causes tamponade, and prothrombotic states give thromboembolic complications such as arterial thromboembolism, deep vein thrombosis, intracardiac thrombus, microvascular thrombi, pulmonary embolism, or stroke. So when a patient comes to the cardiac emergency, all the patients should be handled as suspected COVID-19 with proper protection, with proper PPE, and the level should be 2. And in some cases where if aerosol generating procedure needed, then the protection should be level 3. So proper history, not only presenting cardiorespiratory symptoms, but symptoms suggestive of COVID-19 should also be asked, like fever, loss of taste and smell, and contact history with COVID patient should be asked. Targeted physical examination should be done, but it's better to do the physical examination from the back of the patient. And if the patient is dyspneic, always saturation should be checked. And the appropriate investigations should be targeted to evaluate the cardiac injury with ECG, troponin, NT-proBNP, echocardiogram. Cardiac MRI not necessarily should be done in each and every patient, but if suspected myocarditis, then definitely it gives us information which already been told by Dr. Abida. So other investigations, inflammatory markers, as I have already mentioned that leukocytes we can find, but neutrophil to lymphocyte ratio is very important because it dictates us to treat the patient whether in ICU or in ward. If the NLR or neutrophil to lymphocyte ratio is less than 3, the patient can be managed in the ward situation, and obviously in the COVID dedicated hospital. And other inflammatory markers, if elevated, this also gives a prognostic value, especially the D-dimer. And investigations also should be done to see the patient's lung involvement and oxygenation with saturation, ABG, X-ray, and HSCT. As I have shown the HSCT of the patient, that ground glass opacity and the bilateral involvement of the lungs with opacity or pneumonia as a hallmark of COVID-19. And though it is specific for COVID-19 RT-PCR, if it is positive, then we can confirm the case. But we have to remember that in 30 to 35% of cases, the RT-PCR can be negative. So suspicion, clinical history, and other supporting investigations give us the conclusion to make a diagnosis. And so when a patient comes to us with the acute coronary syndrome, especially ST elevation MI, what to do? If the patient actually presents in the tertiary level cardiac hospital where the dedicated cardiac cath lab for in COVID-19 is there, so the algorithm is same as pre-COVID era, but except that the time is a little bit extended up to 60 minutes, extra 60 minutes are given to take the decision. So if the hospital is not capable of doing is not capable of doing the 24/7 cath lab, or if it doesn't have any COVID dedicated cath lab, so fibrinolysis is the preferred one. In case of non-ST elevation MISCS, we have to group the patient in the very high risk who has actually hemodynamic instability, recurrent chest pain, maybe life-threatening arrhythmias, and mechanical complications, acute heart failure. Then it should be followed as per STMI pathway. In the high-risk group, early invasive procedure can be done after test result, and the target should be within 24 hours. In other patients, we can wait, and after testing the SARS-CoV-2, so non-invasive testing can be done. So in the case of management, though we know that there is no specific treatment, remdesivir has been widely used, though it doesn't have any mortality benefit. It reduces the hospital stay and accelerates the recovery, but we cannot say this is a specific treatment. About the vaccines, still it's a long way to go, we can say. And other investigations, treatment options, many treatment options are being tried. Convalescent plasma interferon beta, tocilizumab, baricitinib, but it's not recommended. Still, it is investigational treatment options. There is a recovery trial with steroids with low dose morning 6 milligram of dexamethasone in the morning dose for 10 days actually gave good benefit. And others are totally supportive cares with oxygen therapy and if needed, then high flow nasal cannula. And if the patient present with heart failure, it should be guideline directed medical therapy. And if the patient is hemodynamically compromised and under props, temporary mechanical circulatory support devices should be given. And if for the thromboprophylaxis, low molecular weight heparin, or even newer novel oral anticoagulant can be used. And for arrhythmia, antiarrhythmic drugs should be used. But many patients after surviving this COVID-19 have continuous symptoms like this ongoing symptomatic COVID-19. They're grouped into this group when they have these symptoms from 4 to 12 weeks. And post-COVID-19 syndromes are actually when these symptoms persist more than 12 weeks and which are not explained by an alternative diagnosis. These are the most common signs and symptoms of long COVID syndromes, So fatigue, shortness of breath, sore throat, cough, chest pain, muscle pain, headache, palpitation, loss of smell or taste, diarrhea, memory loss, depression, sleep disturbance, or hair loss. So I think I should stop here. So thank you. Thanks for patient hearing.
Thank you, Dr. Ishaq Zaman, for your nice presentation on COVID-19 and cardiovascular disease. Now I will request for discussion, first for discussion and some question and answer from Professor Amal Kumar Chaudhary, Professor of Cardiology and ICBD. Amal, please.
Can you hear me?
Yes.
Can you hear me, Devanda?
Yes, we can hear you.
Thank you, thank you, Devanda, for inviting me as a panelist. First, I'd like to congratulate the bright presentation of the two, Abida and Ishaq Zaman. The topics was myocarditis and COVID-related cardiovascular impact. Abida's presentation is very brilliant. She did not escape any, no stone unturned, including the etiology. It should be kept in mind in the examiner's perspective, so that every student can say that some etiology is infectious, non-infectious, and non-infectious is again divided into the immunological and toxic or chemical like this. Then what is the sign and symptom? She nicely described the sign and symptom. What is usually we try to cover in the written examination, because acute myocarditis cannot be possible to give any clinical or practical examination. But some ECG finding or particularly ECG finding can be asked to the examiner in the examination during a short or long viva or ECG setting, or some differentiating point in echo, and also some X-ray. Otherwise, it is no scope to cover except in the giving a scenario like Abida shown very nicely, the 22 years old young man presented with some sort of sign and symptom like this. So I think it is nothing to say about Abida's presentation. It is excellent. Next, I like to comment about the Jawan's presentation. It is also very nice. I don't like to say anything about the ACS. Everybody we know about the management of ACS with COVID in the plaque rupture or thrombotic due to thrombotic damage of the myocardium, including myocarditis. Everybody knows. But some things should be known, because it is a very rampant disease. Every student should know the arrhythmia is one of the source is the use of drug. We use a lot of macrolide antibiotics and also antiviral. They have very, very effect on the prolongation of the QT interval or like this. So it should be mentioned that the drug may cause fatal arrhythmia or toxicity point is in the setting of COVID patient. And also, we discuss everything, but hypertension with COVID, what we did, ESC guideline shows that if the patient did not control, it is a hypo or hyper, so need to change the ACE inhibitor or ARB. If it is hypertension, it should be stopped, and it is not regulated, and pressure become raised. Drug at that sitting, that drug may be changed, but not recommended that ACE inhibitor should be changed routinely. Another point is very important. Even in the pandemic area, in the whole world, there is a lot of patients is undergone PCI. So what about the antiplatelet strategy in COVID era? What about the anticoagulant strategy in COVID era? So it should be I think every student should know very meticulously what will be the antiplatelet strategy after PCI. Complex PCI, if we will give the dual antiplatelet or very potential antiplatelet for 1 year. So in that case, what will be the strategy? If it is less than 3 months, it's okay. It should be continue in dual antiplatelet until and unless platelet count less than 50,000 should be kept observed. Is there any bleeding tendency? And below 10,000 antiplatelet should be single. And if it is more than 3 months, any PCI, it is recommended that the single antiplatelet is enough in the COVID patient, apart from COVID or in the COVID era. And another aspect is less addressed in the COVID era is the CCS. ACS is very tremendous discussion is there. What about CCS? In the last 1 year, anybody chronic coronary syndrome patient may suffer, may change to the mild to moderate symptom, moderate to high risk, very high risk symptom or like this. So need to revascularization. So how we will categorize this patient? So the news, the message is that if it is stable with the optimal medical treatment or guideline determined medical treatment, it's okay. Optimal, every cardiologist should try to keep the sign symptom of CCS patient in by drug. If it is failed, then use of CT angio rather than use of other like ETT or echocardiography. CT angiogram may be the good tool or whether patient need to invasive procedure or not. If it is needed to invasive procedure, PCI is the choice other than CABG, if it is possible. PCI revascular strategy. If PCI is not possible, patient should be referred to a cardiac surgery department where there is no COVID hub. That hospital have no COVID, no red zone, no yellow zone, only green zone, and that hospital only deal the CABG. And PCI can be done in a moderate to high risk patient. Need to do some group of CCS patient because there is all of you know there is 5 group of CCS patient. So medical treatment should be optimized. If it is failed, it is categorized or it is optimized by doing the CT angio. If it is indicated to the revascularization, PCI is that choice. If it is not possible, surgery is needed, then refer to the non-COVID hub. And about anticoagulant, we know if atrial fibrillation after PCI or like this, everybody we know the how should we use or the dose of anticoagulant, what will be which novel anticoagulant should be used like this. I think everybody we know. So the less addressed topics in COVID is the CCS should be kept. Every student should keep in mind. Hypertension is less, and post PCI because lot of PCI is going on whole of the world in every month. So after PCI in the COVID era, including COVID patient or without COVID, how we will deal the antiplatelet and anticoagulant, it should be known every person. Thank you, ma'am. Thank you, Divanda. This is my comment about these 2 presentations.
Thank you, Dr. Amol, for your nice discussion on the myocarditis and COVID era treatment of ACS and post-COVID complication. Now I'll request Dr. Mohammedullah Firoz to say something on this topic, 2 topics. Firoz, please. Dr. Firoz, please.
Thank you, Dimanda. And it's a great privilege to be part of this webinar. And thank you, Professor Fazila Madam, for the kind introduction of me at the beginning. This is a very important topic for the students, for us, and for every cardiologist, I think, everywhere in the country and everywhere in the world, I think. Because even if we think about myocarditis 3 years back, if I would ask about the cause of myocarditis, I will say rheumatic myocarditis and connective tissue diseases, and hardly sarcoidosis. But over the last 3 years, dengue and COVID has changed the scenario of myocarditis. We have seen many patients dying of myocarditis during the dengue last year, and this year COVID has brought this myocarditis in broad daylight. Myocarditis, Dr. Abida missed one thing at least, that is the prognosis of myocarditis. She has covered brilliantly every aspect of myocarditis. Prognosis of myocarditis is very important, because if a patient has got myocarditis, we are going to lose 20% of them at the end of 1 year, and you are going to lose 40% of your patient at the end of 4 years. So it is prognostically, it is not less important than a myocardial infarction. This is also important thing. Everyone should know it. And for the students, as an exam purpose, this is an important question. For next 1 or 2 year, myocarditis would be a very important question for you. Regarding the etiology, definitely post-viral or dengue or COVID myocarditis are coming in front at the top of the list probably now. And regarding the treatment investigation purpose, one important thing in echocardiography for myocarditis, mostly you have to differentiate it from myocardial infarction. In case of myocardial infarction, it usually follows a arterial territory. In case of myocarditis, commonly it is a global one, but it can be a focal one, as Dr. Abida said, that it can be a focal myocarditis. Regarding the ECG, the myocarditis can produce almost any sort of ECG changes, any sort of arrhythmia, bradycardia, tachycardia, T inversion, ST elevation, or ST depression. So for any sort of ECG in exam, you should bring myocarditis as a differential diagnosis, at least now. This is important thing. Dr. Abida nicely talked about endomyocardial biopsy, bioptonem endomyocardial. It is a very good short note question for us, for the student, and we Bangladeshi cardiologists are lacking this bioptem procedure or endomyocardial biopsy. Regarding the treatment, I think as Dr. Abida, is digital is a good option for myocarditis treatment?
Abida, you have a question?
Abida, is digital is a good anti-failure drug for myocarditis?
Sir, I didn't get the. Sir, actually, I couldn't hear, sir.
Will you prescribe digitalis for heart failure with myocarditis?
Oh, sir, actually, sir, I've seen some texts that in heart failure with myocarditis patient, they are giving, they have seen that digoxin has good effect in controlling the symptoms, sir. Actually, sir, the details actually I cannot, sir, mention.
Most
sir,
of the text mention that digitally has got a pro-arrhythmic effect, especially during the time of myocarditis. So you shouldn't use it as the first line drug, I think. This is an important one. Another important one is regarding the use of steroid. Definitely you can use steroid in case of rheumatic myocarditis, in case of connective tissue myocarditis, sarcoidosis, and probably also in COVID myocarditis, though it is not established. But in case of post-viral myocarditis, steroid and IV immunoglobulin almost have no effect. And what about the another important thing we are asked during rheumatic myocarditis regarding the rest of the patient, how much time you will allow the patient to take rest at home, bed rest, and all these things, because in myocarditis is a disease process where you may need to ask the patient to take rest for 3 to 6 months. Yes. 3 to 6 months, depending on the severity of the patient. This is an important viva questions in our time, probably also now in this time. So for the treatment, rest is an important one. Regarding this second lecture of Dr. Mir Ishaq, COVID with cardiovascular disease, it is a big chapter and very important chapter. You have tried to mention it in a precise way. You have mentioned it very good. I think this is an important thing because COVID with myocarditis has got a high mortality rate, and definitely you have mentioned about different markers by which we can identify the patients who are going to face this high mortality rate. One important thing. Another important thing regarding the treatment, many of the COVID patients have got silent myocarditis. That means they haven't got any feature in echocardiography or other things, but CMR is detecting that they have got some features consistent with myocarditis. And we don't know about the late sequelae of this myocarditis, how they will behave in future, how will they turn into cardiomyopathy, as Dr. Abida said, or any sort of arrhythmia. But definitely, I think each and every patient who is being hospitalized for COVID or who has got hospitalized for COVID in the ICU should go a follow-up echocardiography to exclude myocarditis. This is the few words about Ishaq's presentation, but both the presentations are brilliant, and I think each and every student should go through these two chapters: myocarditis, how you can diagnose it, what are the features of myocarditis, what are the ECG features of myocarditis, how you can differentiate myocarditis from myocardial infarction, how we can differentiate myocarditis from pericarditis, what is myopericarditis, and what should be the treatment modality for myocarditis, when you are going to use steroid, when not, how much time you will allow the patient to take rest, and in case of COVID and cardiovascular disease, how you are going to manage these cardiovascular patients with COVID. And as Professor Amal Sir mentioned, different complex things. I think you can also keep in mind all these things. Thank you. Thank you, Dhimanda.
Dhimanda, can I ask one question to Abida?
Yes, you can ask.
Abida, regarding the Dr. Mohammed Firoz comment, for the diagnosis of the myocarditis, which one is superior, whether endomyocardial biopsy or cardiac MRI?
Sir, endomyocardial biopsy is the gold standard, sir. If we want to make the definite diagnosis, we have to go for endomyocardial biopsy. But we can do, at least in our setting, if we could start doing cardiac MRI, that could be a very good investigation as well, because we can see non-invasively all the changes that usually found in myocarditis. So I think it is also an important tool for investigation.
Thank you. But Abida, you must know that the endomyocarditis, you have already mentioned that there is also focal myocarditis.
Yes.
If you sample more than 5 plus, if you do a study, 2 plus sample, 5 plus sample, and 7 plus sample, it shows that the 7 plus sample, the diagnosis is more than is you taken the sample 2 plus. So, and also hazardous. So, considering this, the cardiac MRI is very important. It does not exclude any part, focal or anterior wall myocarditis or regional myocarditis or like this. So, not bad. The cardiac MRI is very nice imaging to detect the myocarditis. But it is the gold standard, but it has got a lot of hazards and also pitfall and also some shortcome.
Yes, sir.
Thank you.
Thank you, Dr. Firoz, Dr. Amol, for the brilliant discussion on this topic. Many questions have been asked and many questions has been discussed. Student, there was a question in the chat box. This has been answered by our Dr. Firoz. How will you differentiate it between MI and myocarditis in emergency department, and how will you manage? This question has already been answered by Dr. Firoz. Now I will request Fazila Madam to say something. Madam, please.
Well, actually, I don't really have much to say because everything has been so beautifully covered by our panel of experts. What I just wanted to highlight is that I saw one of the comments that one of the students or attendees wanted the soft copy of these presentations. So just to let you know, Dr. Kolim has already uploaded 3 presentations already. The next 3 will be uploaded within a couple of days, because a very important announcement, Dhiman will again announce it, but just very briefly, we will be having an evaluation test like we had for our first term, we'll be having an evaluation test on these lectures. You will be given the list of the lectures, and that will be on next week. So Dhiman will be going into the details of this once the session concludes. But we will, of course, be uploading all the presentations so that you can view them at your own pace and leisure, and you will be suitably prepared for the MCQ tests and as well for your exams. So that's what I wanted to say. Thank you.
Thank you, madam, for your talk. Now I'll request Bodhijaman sir. Sir, any comment on this lecture?
Thank you, Dr. Dhiman. Actually, as Professor Fazila Malik has rightly mentioned, nothing much to add. Already both the speakers have delivered very beautifully all the topics, and the two expert panelists, Dr. Amol and Dr. Firoz, has already discussed almost every aspect of the two topics. So I think nothing much to add. Thank you, both the speakers and the panelists, to enlighten us with the knowledge, and thank you. I think we should proceed to our next lecture. Thank you,
Yes,
Dr. Dhiman.
Thank you, sir. Next, our next, sir, madam, we will proceed to the next lecture.
Yes, please.
Our next lecture is on cardiac tumors. It will be presented by our registrar, Dr. Shamim Chaudhary. He will be presented on cardiac tumors. Shamim, Dr. Shamim, please.
Assalamu alaikum, honorable panel of expert, respected moderator, my teachers and learned audience. My topic of presentation will be the tumors. Majority of the cardiac tumors are the secondary tumors, usually metastasis from lung, breast, ovary, thyroid, lymphoma, and malignant melanoma. Malignant melanoma is the more rapidly progressive malignancy. Among all the secondaries, lung metastasis is the most commonest one. Regarding the primary cardiac tumors, benign tumors are the common. Among the myxoma, lipoma, and papilloelastoma are the common. However, the primary malignancy are rarest, and majority of them are the sarcomas. Primary cardiac tumors are the rare, occurring approximately 30 times less frequently than the cardiac metastasis. Approximately 75% of the primary tumors are the benign tumors, and among them, myxoma accounts for the 50% of the primary cardiac neoplasms. Most malignancies of the heart are secondary, and they involve mainly the pericardium and usually are the carcinomas. Tumors usually spread to the heart via direct extension or the circulatory system or via lymphatics. The most common metastatic tumor is the lung cancer. Among the lung cancer, the adenocarcinoma is the most common. The typical presentation is the pericardial effusion or sometimes tamponade or pulmonary vein obstruction from direct extension. Primary malignant tumors are virtually always sarcomas. Now, the clinical presentation of the cardiac tumor usually depend on the size and location of the tumor. The left-sided cardiac tumors usually manifest as a cardioembolic symptoms like stroke, TIA, or sometimes peripheral embolization. And large cardiac tumors usually present with the features of obstruction or valvular dysfunction. Tumor may present with the features of compression or mass effect. However, sometimes it is incidental finding with the features of atrial or ventricular arrhythmias on ECGs. Tumors involving the pericardium can cause pericardial effusion and sometimes with tamponade. The classical triad of the presentation of the cardiac tumors are some constitutional symptoms, embolic phenomenon, and direct cardiac invasion mass effect. The constitutional symptoms are usually due to the release of some cytokines, inflammatory cytokines like interleukin-6, antimyocardial antibodies. The features are the fever, chills, cachexia, weight loss, arthalgia. The embolic phenomenon is more common with the left-sided tumor that may present with limb ischemia or transient ischemic attack or stroke. However, right-sided tumor and left-sided tumor with left to right shunt may result in pulmonary embolism. Now, the common routine investigation, what can go for the confirmed diagnosis are the ECG. There will be no specific criteria. There may be arrhythmia or low voltage ECG due to pericardial effusion. On XHS PA there may be cardiomegaly with the mediastinal widening or cardiac silhouette irregularities. Echocardiogram is the hallmark for the diagnosis of the cardiac tumors, including the transesophageal echo. And cardiac MRI and CT can be done to see the extent of the disease and to see the other size of the tumor. Other investigations are like the complete blood count with ESR, acute phase reactants like CRP and interleukin-6 can be done. Now the myxoma. Myxoma is the commonest tumor, benign tumor of the heart. It is a friable and gelatinous tumor of connective tissue origin resulting from the germline mutation. It is more common in women than men. Generally, it is found in the 4th or 5th decade of life. Approximately 75 to 80% myxomas occurs in the left atrium, with 20% occurring in the right atrium, and only 3 to 4% can be found in the right and left ventricle. 90% of the myxomas are sporadic, and around 10% of the familial. They are usually present as a lobular left atrial mass attached with the interatrial septal, often in the region of fossa ovalis via pedicle. Myxoma may present as a part of a clinical syndrome. Pathologically, myxomas are either smooth or round, or sometimes it could be a friable or irregular in appearance. Myxoma can present in the part of a syndrome like the name syndrome that is included navy, atrial myxoma, myxoid neurofibroma and affiliates, or can be a part of a Lamb syndrome that is Landigens, atrial myxoma or blue nevi. However, these two can combine with a complex or syndrome like Carning complex, that is a cardiac and extracardiac myxomas with spotty pigmentation of the skin, endocrinopathy, and other neuroendocrine tumors. This is the picture showing the Carning complex with cutaneous myxoma, cardiac myxoma, and other mammary myxoma, including some tumors with spotty pigmentation. Now the symptoms of the myxoma. Usually myxoma present with any or all of the triad of the symptoms like constitutional, obstructive, or embolic phenomenon. Symptoms may be sometimes vague and include low-grade fever, lethargy, arthalgia, and weight loss. However, obstructive symptoms will due to the mitral inflow obstruction and present like the features of mitral stenosis. Sometimes embolic phenomenon may be found due to fragment of myxoma can embolize to remote vascular locations. Now, on clinical examination, usually the findings of the auscultation, the first heart sound will be loud due to delayed closure of the mitral valve due to the obstruction by the tumor, and tumor plop, that is the early diastolic high-pitched sound produced by the tumor, which is earlier than the third heart sound, but later from the opening snap. Sometimes it occurs with the diastolic rumble. And there will be mid-diastolic murmur in mitral area, which changes its posture. Now, features of the pulmonary congestion and right heart failure can also observe if there is an obstructive variety of myxoma. The echocardiographic, the findings will be round mobile mass in the left atrium arising from the fossa ovalis in the interatrial septum, attached with the interatrial septum and prolapsing into the mitral valve orifice. Mitral valve will be of normal in its structure and excursion. This is the picture left side. This is a picture, still picture showing the myxoma in the left atrium, which is attached with the interatrial septum, and the right one is a moving picture showing there is a myxoma obstructing the mitral inflow. And the typical M-mode characteristics, which shows that there is multiple linear echoes and around the tip of the cursor in the anterior mitral leaflet. And there will be multiple linear echoes within the mitral orifice and within the left atrium. In addition, there is a time gap between the opening of the mitral valve and the prolapse of the myxoma into the valve orifice. And this is another picture showing there is an obstructing left atrial myxoma with some features of mitral inflow or obstruction as found by the mosaic flow. Now, this is commonly encountered in the exam, that is difference between atrial myxoma and atrial thrombus in echocardiography. Usually myxoma is the site is the atrial septum and the thrombus will be in the posterior wall. Myxoma will be pedunculated attachment and atrial thrombus will be free. Myxoma size shape will be lobulated and the atrial thrombus will be rounded. And regarding the echogenicity, atrial myxoma will be echolucent and atrial thrombus will be the echogenic. Mitral valve will be the normal in case of myxoma and it will be diseased in case of thrombus usually. And prolapse in the mitral valve will be often found in case of atrial myxoma. However, it will be rare in case of atrial thrombus. Now, the complications of myxoma are with the congestive heart failure, embolization, sudden death, infection, rupture, and myocardial infarction. The treatment of myxoma, obstructive left atrial myxoma is a surgical emergency. Surgical resection of the myxoma is the only definitive form of treatment. Long-term prognosis is excellent. The recurrence rate is 1 to 5% in case of sporadic myxoma. However, it is more higher. There's 20 to 25% in case of familial patients. And it was advised that annual follow-up of non-invasive imaging is recommended after surgery. However, in case of familial or syndromic patient, it is advised that biannual follow-up of non-invasive imaging should be done. Now, another important is the papillary fibrillostoma. It is the most common valvular tumor. Third most common cardiac tumor after myxoma and lipoma. Most usual location is on the mitral and aortic valve. In case of aortic valve, it is on ventricular surface, and mitral valve, it is on atrial surface. Usually, papillary fibrillostomas are often small and appear flower-like with a narrow stalk. It is often diagnosed as incidental diagnosis at the time of routine echocardiography or catheterization or surgery. Usually, papillary fibrillostoma present as acute coronary syndrome or due to the ostial coronary obstruction leading to myocardial ischemia or infarction. If symptoms occur, they are usually left-sided tumors. However, right-sided tumors are rarely symptomatic. Indication for surgery at the symptomatic patient and in case of asymptomatic patient with a large mobile mass. And this is a picture of our hospital that was presented in the Europe PCR in 2018, a case of papillary fibrillostoma in the aortic valve. And this is showing in the ventricular surface in the right side, there is an aortic mass. And this is another picture showing the large undifferentiated sarcoma in the left atrium. Now, I'm ending the presentation with a scenario. A 42-year-old woman presented to the outpatient department with frequent fainting spells in the preceding 2 weeks against a background history of exertional breathlessness. She had also noticed a low-grade fever and unintentional weight loss for 4 kg in this period. On examination, she was mildly pale and dyspneic, but not in any distress. Her heart rate was 96 beats per minute with blood pressure was normal and her temperature was a little bit high, but there are no signs of congestive heart failure. On auscultation, there is a mid-diastolic rumble at the mitral area preceded by a high-pitched third heart sound. Now, with this scenario of history of dyspnea, constitutional symptoms, and febrile illness, and with a cardiac murmur, the possibilities are in our context, the mitral stenosis, probably due to rheumatic heart disease, the atrial myxoma, and the least possibility will be the infective endocarditis. However, now we have to go for the clinical differentiation between left atrial myxoma and mitral stenosis. Usually, in myxoma, opening snap will be absent, but there will be tumor plop will be present. That is quite similar, and differentiation from opening snap and tumor plop should be done. Both are early diastolic murmur, but the tumor plop will come earlier rather than the opening snap. And the murmur that changes the posture that goes in favor with the left atrial myxoma, and presystolic accentuation will go in favor for mitral stenosis. However, constitutional symptoms will be present in left atrial myxoma, but in case of mitral stenosis, usually they are absent. And echocardiographically, in mitral valve will be of normal morphology in case of left atrial myxoma. However, in case of mitral stenosis, there will be mitral valvular changes, commonly the rheumatic. Now, with this scenario, in our case, the mid-diastolic murmur that changes with the posture, and also the third heart sound, the preceding the murmur was the tumor plop, not the opening snap. And the echo revealed a round mobile mass in the left atrium arising from the fossa ovalis of the interatrial septum and prolapsing into the mitral valve orifice, causing mitral inflow obstruction. So this is a case of left atrial myxoma. Thank you all for patient hearing.
Thank you, Dr. Shamim Chaudhary, for your nice presentation on an important topic of cardiac tumors, especially on myxoma. This myxoma is commonly asked in the exam, coming in the differential diagnosis in the written, and with echoes in the Viva table echo, or in the OSPI, or in the spotting. So with this presentation, I will now request Professor Dr. Amal Chaudhary to discuss about tumors, what are the question is asked, and what are the tricky question can be asked in the question regarding this presentation.
Thank you, Devanda. This is also very nice topics. Today's already discussed topics is also nice for written as well as Viva, and this topic is very much important. One student can pass and can get that, take the opportunity to pass by myxoma in short case, in long case, even in Viva, or particularly echo in contrast with the LA thrombus or like this. So it is a very common hot topics which has been asked in every exam, including written and also Viva, as well as also echocardiographic picture, and also some tricky question in the short case and long case. So everybody should know how to differentiate between clinically, very important, clinically how to differentiate it between severe MS or moderate MS to LA myxoma. There is one question, and Shamim have every time told the rambling murmur, but it is typically for MS patient. But I think I like to say that if ER is very nicely acquainted with the sound, 10 cases of LA myxoma obstructing the mitral valve and 10 cases of pure moderate to severe MS, it will differentiate the murmur definitely. Because the murmur is little harsh, and there is a effect is called wrecking ball effect in the start attached to the interatrial septum, and every time it plops into the through the anterior and posterior leaflet of the mitral valve, and it destroys the gradually in the leaflet and produce the wrecking ball effect, the used to break the stone or mountain like this. So there is some harshness of the murmur, and also the regurgitation component may present with the diastolic component. So mixed together diastolic component as well as regurgitant component produce a very harsh type of murmur is the characteristic of clinically to detect the characteristically the LA myxoma. And postural differentiation, it is very nice. The murmur have been changed with posture. It is also very important to keep the student. It is a sticky question asked, how to differentiate and how to see what is the posture with potentiate the murmur, what is the posture which subset the murmur intensity in the LA myxoma, and also its management. is also very important. Everybody, you have mentioned that it is a surgical emergency sometimes, but practically we saw the long time that some people, ladies are suffering from the LMXoma, coming to the hospital for operation, then go back, and also coming with some embolic manifestation like stroke. So everybody, every student should keep it every pros and cons of the LMXoma. It is a very good topics for examination in both practical as well as echocardiography. And I think uh, nothing to say. Shamim has discussed everything and every corner. Thank you. Thank you, Dhivandar.
Thank you, Dr. Amol, for your discussion. Now I will request Dr. Mahmudullah Firoz for saying us something about this topic.
Thank you, Dhimanda. Dr. Shamim Chaudhary has brilliantly mentioned all the things regarding the classification, incidence, prevalence, and the most common cardiac tumor, myxoma. He has described everything beautifully. In fact, cardiac, if we think on the perspective of the student, it is very important for the student to go through these few things. One is cardiac myxoma. That is important thing. Regarding in short note, it is important. In case of written, when some question is mentioned about with murmur with fever, this is a common question, paid question for the examiners. So one of the important cause is infective endocarditis, but myxoma is always a differential diagnosis of this infective endocarditis. This should be kept in mind. Regarding the clinical examination, in mitral stenosis, we always say there is a differential diagnosis of left atrial myxoma. This is also important, and Dr. Shamim and Amal sir has mentioned beautifully how to differentiate between mitral stenosis and this left atrial myxoma. One important thing in clinically, if your patient has got atrial fibrillation, it is mitral stenosis. It is never most unlikely to be left atrial myxoma. This thing should be kept in mind. In echocardiography also, the myxoma is given as a in OSPI exam or in the board exam to show what is the diagnosis of myxoma, how we can differentiate from thrombus with myxoma, and Dr. Shamim has mentioned how to differentiate between myxoma and thrombus. But sometimes students go through all these points. Sometimes some irregular, non-homogeneity, margin surface. But to me, two most important points to differentiate between thrombus and myxoma is one is mitral valve, whether there is mitral stenosis. If the echocardiography is showing mitral stenosis, this is thrombus, unless mentioned, unless proved otherwise. Second thing, atrial fibrillation. If there is a ECG and it is showing atrial fibrillation, the diagnosis is thrombus. Third thing, spontaneous echo contrast. If there is spontaneous echo contrast, the diagnosis is thrombus, unless mentioned otherwise. So these three important points should be mentioned, should be told first in the Viva table. That if the mitral valve is, if there is mitral stenosis, if there is atrial fibrillation, if there is spontaneous echo contrast, the diagnosis is thrombus, and otherwise it is myxoma. And definitely the morphological character of myxoma and thrombus is also important. These are the things in regarding the echocardiography, and he has also mentioned everything about the papillary fibroelastoma. But to me, in case of papillary fibroelastoma, the embolic features or embolic presentation is more common than the coronary features. If you think the papillary fibroelastoma is on the ventricular surface of the aortic valve. For coronary obstruction, you have to go on the aortic side of the aortic valve. Most common presentation of papillary fibroelastoma is thromboembolism, and indication or the surgery is done to prevent embolism, not to prevent the obstruction of the coronary artery. Another important thing I should suggest for the students is malignant pericardial effusion. This is very common in our clinical practice, and this is also asked in Viva table with pericardial effusion. and also in written question that how a malignant pericardial effusion can be managed, how a pericardiodesis can be done, and what are the features. I think these are the three common features every student should go through regarding myxoma, regarding papillary fibrillostoma, and malignant pericardial effusion. And thank you, Dhivanda.
Thank you, Firoz, for a brilliant discussion, giving us the important clue for the students regarding the tumors. Now, I will request Nazir Ahmed sir. Sir, anything regarding this presentation, sir?
Thank you very much, Dr. Dimanda. Nothing to add. It's a very wonderful session. And I like to thank Dr. Amal Kumar Chaudhary and Dr. Mahmoudullah Furi for their presence and their comments. And I also like to thank all the lecturers, presenters for their beautiful presentations. And already time is over. I think I like to stop here. Thank you very much.
Any comments from the other panelists? Dr. Ashok, Dr. Tawfiq Shariar Haq? Madam, anything from your part? Any comments?
Madam, unmute. Madam, unmute, please.
Yes, so thank you for being such great panel of experts. I would really like to thank both Professor Amol as well as Dr. Firoz for their insightful comments. I think the students will be truly benefited from them. And as Professor Nazir has already highlighted, our three speakers were absolutely great. And Firoz, actually, we had a session on pericardial effusion, and all those things were actually covered. So we've been having these lectures every week from a student's perspective. And next week, inshallah, the exams are there, the MCQs evaluation. So I hope everyone takes part. And I would request Dr. Kaleem to upload all the presentations, pericardial effusions, cardiomyopathy, today's lecture, hypertension, heart failure, all the 6 topics on which the evaluation will be done as soon as possible, so that next week our students can benefit from the MCQ. With that, I would like to say thank you to everyone.
Thank you, madam, for your ending remarks. Next week we'll be sit for the exam. The topics are hypertension, heart failure, pericardial disease, cardiomyopathy. All the three have been discussed: dilated cardiomyopathy, ischemic cardiomyopathy, hypertrophic cardiomyopathy, and the restrictive cardiomyopathy. Today's topic also myocarditis, cardiac tumors, and COVID-related cardiovascular disease, as madam already mentioned. So, madam, should we conclude this session? It is 9:30.
Please. Yes, please, you go ahead and conclude. Thank you.
Thank you, Dr. Firoz and Professor Amal, for coming to this webinar and giving us the very important information.
Thank you, Dhivanda.
Thank you, Dhivanda. Thank you, madam. Thank you, everyone.
Thank you all. Thank you all for coming and give the webinar a beautiful appearance. So thank you all for patient sharing, and thank you. Good night.
And best of luck with your next week's exams. Yes, bye.